Good morning, good afternoon, everyone, and welcome to today's Educational Round series. So we're taking a new approach with this session. Before I continue, I just want to make sure you can all hear me clearly. Perfect, thank you. So this session and the subsequent two sessions is going to follow a new format, and I'll go through the new format later on in the slides. So it's a multidisciplinary treatment case rounds in tobacco cessation. Okay, and as always, if you are interested in obtaining a letter of completion for this session, you must have registered and completed the pre-learning assessment, sign in to view the live webinar session using your first and last name, and complete the evaluation and post-learning assessment following the session. These webinars are being live tweeted on Twitter. Follow the CAMH Nicotine Dependent Services on Twitter at @PSQuitSmoking. To follow the live tweeting or to post your questions or comments, use the hashtag #TeachWebinar. And our first faculty presenter today is Dr. Peter Selby. He is the Director of Medical Education and a clinician scientist at the Center for Addiction and Mental Health. And I'll let you read the remainder of his long bio later on. As well, we have Melonie Ceresne, who began her career at CAMH in 1999 as an occupational therapist, and she works at the Nicotine Dependence Clinic as a therapist. And lastly, we have Alexandra Andric. She is the registered nurse who's worked at CAMH since 2006, and she is the nurse on site at the Nicotine Dependence Clinic. Our disclosures, Dr. Selby's disclosures, none for Melonie or Alex. The TEACH curriculum and slides were developed and compiled with funding from the Government of Ontario, specifically the Ministry of Health and Long-Term Care. Contents of the slides are primarily based on evidence-based guidelines from the following sources. Disclaimer, these materials, as well as the verbal presentation and any discussion, set out only general principles and approaches and do not replace the need for individualized care. Okay, so now on to the new webinar format. So on the registration form, we gave you, the participants, the option of submitting a complex case that you are currently struggling with. So today's session will take on one of those cases that were submitted, and you can actually download it right here, case summary, so you can see the case that we submitted. So we're going to begin with the update in the relevant literature. Then we're going to have, hopefully, the person who submitted the case present and summarize the case presentation. Then there'll be approximately 20 minutes for clarification, feedback, and discussion. And then next, recommendations by panelists, and then final thoughts and questions. Can you all hear, or are there audio difficulties for everyone? Okay, perfect. So I will continue then. Okay, so this is the learning objectives. Now, before we begin, we're going to do our usual polling just to get a sense of the group that we have here today. So the first question is asking what type of organization you work for. Please select your responses.
Are we recording this?
Okay, great. Looks like the majority of you are public health units and family health teams. The next question is asking for your current discipline. Now, it's a long one, so feel free to scroll down. Okay, overwhelming majority of you are registered nurses. That's great. And then the final question is asking what region you are from. Most common Eastern area and Central East. So thank you for participating in the poll. I am going to now introduce the presenters. So from the left side of the screen to the right, we have Melonie, then we have Alex, and then we have Dr. Selby. So now I'm going to check in with the group to see if Crystal Ferguson has joined us to present her case. Crystal, if you are on the line, please push *1 on your phone to unmute.
See that?
Hi, it's Crystal here.
Hi there. I'm happy that you were able to join us.
Yes, thanks. Did you want me to begin now, or?
Yeah, for sure. Yeah, go ahead.
Okay. So we have a client here. He's 72 years old. He's been in the smoking cessation kind of program on and off since about 2013. And he typically smokes when he's around 30 to 40 cigarettes a day. Sometimes it can be more than that, but he stops tracking after he gets to about 30 or 40. And he's tried to quit or reduce on several different occasions over the last couple of years that he's been working with us at the Community Health Center. He's tried Chantix and also NRT, and he's also tried to just quit on his own with behavioral strategies as well. He does live alone, and he describes himself as an introvert, and I think from like a healthcare provider or that sort of discipline, he is somewhat socially isolated as well. He doesn't really get out of his home and participate in any sort of kind of social activities very often. And when he does, he has to really put a lot of emphasis and effort into that. He has a limited income as well, and he has COPD and a history of alcohol abuse. And so I guess what we're wondering is, just strategies for working with this client. We've tried lots of different strategies, as you can guess, but there is a thought. He sees our nurse practitioner and also our social worker as well for some additional counseling, and has been kind of back and forth between social work and the tobacco cessation program, also working together with the two of us on smoking cessation and just other kind of challenges. There is a concern that there's maybe some perhaps mood disorder like dysthymia, but the patient is really not interested in exploring diagnosis or treatment, is the feedback that we've received from the nurse practitioner and the social worker. More recently, too, we're starting to see that there's maybe some anxiety that's going with. So as he starts to see some success with his reduction and cessation efforts, there seems to be some anxiety going on, and then there'll be a relapse. This client also over the years been interested in some peer support, but we don't have any kind of peer support programs in the community, and we don't really have a lot of capacity to start a peer support program. We have tried to refer to kind of things like Smokers Helpline online and things like that, but that's been met with limited success, so just wondering on some ideas for that. And this client also has kind of struggled with really recognizing and, I don't know if valuing is the right word, but understanding the impact that pharmacotherapy can have in a positive way in a quit plan. And so he somewhat, really understands that it's a psychological piece as well, and so that's great that he understands that piece and the behavioral pieces that go with it, but then kind of minimizes the impact that perhaps NRT or prescription medications could have. Does that give a bit of an idea of where we're at with this client, or should I continue with kind of some of the other history for this client then at this point?
Yeah, for sure, yeah.
Okay. So as I said, the patient has been engaged on and off in counseling support, whether it's with a social worker or myself, I'm the health promoter, for 3 or more years at this point. The patient consistently, there's sometimes, you know, we've questioned whether or not the patient actually is interested in quitting smoking, or if he's coming to the center for some socialization, but the patient really consistently identifies that he does want to quit smoking and that this is an important goal to him, even though sometimes it may not seem like that. You know, when we have those discussions and we use some of the rating scales and tools, that is consistent. And he will establish a change plan. However, each time he does that, he continues to kind of struggle with the motivation, he calls it, to carry out his plan. And as I mentioned previously, there's been some recent discussion around how anxiety might be playing a part in that. He has been, again, engaged in social work and to the nurse practitioner to talk about motivation, but just kind of the unwillingness to explore any more additional support in terms of diagnosis and treatment around potential mood disorders and kind of addressing that problem of motivation. I know the social workers tried a variety of different typical strategies that should use for clients who are struggling with what they would call motivation, and just has been met with limited success that way. We've tried a variety of NRTs, so we've tried patch, lozenge, and inhaler. The patient's tried Champix twice in the past. We did try to start him on some Zyban as well this last time instead of Champix, but the patient was really keen on talking to the pharmacist, which is great, and we support that, but the pharmacist kind of directed him towards the Champix rather than the Zyban, so we haven't been able to readdress that, but it is something kind of still on the option list. I've talked about, I think, the next point in terms of the psychological components, and he is a bit hesitant to use pharmacotherapy, so often he'll really try to use a behavioral change plan first, and then if he's having limited success, and he's like, oh, okay, well, maybe I'm ready to try the patch again, or yes, maybe we could try a prescription medication this time, but he's a little bit hesitant to use, especially prescription medications, but really any sort of medication. And not just in terms of tobacco use, but in other aspects of his life as well. Although the patient it's interesting because the patient has really had some good success cutting down using pharmacotherapy and also behavioral strategies. He has had some really good success doing tracking of his cigarettes, just distracting himself, delaying. Often some kind of key barriers that have really been, you know, that isolation in the home and what is he going to do and the need to get out of the home, and then that's where the motivation comes in. He has been able to break out of that cycle in the past and attend a variety of our different community programs. But again, then all of a sudden something happens, which is seeming to be a bit of this anxiety piece, and he kind of slips off, or the mood might drop down a little bit, it seems, and we go back to kind of a relapse and starting kind of almost over again, but still recognizing those lessons learned. So he's really good at identifying that, especially if we're there to kind of support in identifying and helping him recall some of those strategies he's used. Most recently, so up until just this past few months, he's only wanted to cut back ever as a strategy to quit, and most recently he has actually agreed to set a quit date, and so he actually tried to set a number of different quit dates. You know, he set a quit date. He did have some good success the first time. He went a whole morning without smoking, which is kind of the longest this patient has gone without smoking in quite a number of years. So that was a really big success, and he continued to try to set a number of quit dates over the next few weeks, building on some of those strategies and revising his quit plan to address kind of some lessons learned and some triggers. But then it seemed like there was maybe, again, some of that motivation is what he called it, and challenges with following through on his quit plan strategies, and perhaps we're wondering again about the anxiety piece. So this client also does have COPD, as I mentioned, glaucoma, and he has had a history of alcohol abuse. He hasn't used alcohol in a number of years, though, but that it has something that he's been drawn on, lessons learned and experiences that he's drawn upon in terms of developing his quit plan is how he quit using alcohol as well. So I think hopefully that gives a bit of an overview for people on where this client is at and kind of the background on kind of different strategies that and approaches that we've taken together.
Perfect. Thank you, Crystal, for sharing. So now we're going to head back to the previous slides, and we're just going to cover some relevant issues that may be affecting your case. So let me just, okay, so here's the first slide.
So hi everybody, thanks for joining, and thanks for giving this a go, and we're going to see how this active learning helps us, and thank you so much for that case. I think I'd love to know, what I'm presenting is to know how many other people on the line on the webinar have seen similar kinds of situations and similar kinds of people suffering through these multiple issues, and we are really trying hard to help them. So here the issue that we are hearing is that okay, so there's the alcohol piece, and when people drink alcohol, we know that actually reduces their chances of success in quitting, but there may be some other shared factors as to why people who have one addiction actually have another addiction, and they have a more severe addiction. So you can see in this situation, he's like 30 to 40 cigarettes per day. So very quickly, looking at the pattern, binge drinking is when people have more, for men, more than 5 standard drinks on any one occasion, and for women it's 4, and so that's an easy way to remember. Or the other one is 24 a week or 17 for a week, and these are standard drinks. So that's like a 341 ml bottle of beer, or 5 ounces of wine, or an ounce and a half of spirits. Heavy episodic drinking or heavy drinking is really the drinking, episodically drinking up to that 4 or 5 amount, but not going above it. And in a week, they're spreading it over several days. They're not necessarily hitting that definition of binge, but they're just drinking heavily every day. And these people tend to be functional. Both groups tend to be functional for the most part. And again, we know when we look at quitting, and you look at people's ability to be quit, if they drink, clearly their continuous absence is about half that of what you would expect in non-drinkers, and it appears right from whether they're able to stop for the short term or the long term. You can see this difference. They're not able to quit, and if they do quit, they're unable to maintain their sobriety. The good thing in the case that we talked about is that he's been attending AA and not drinking, so that's a good prognostic feature that one needs to build on. Of course, when people drink and smoke at the same time, they have a very high risk of cancer, especially the oropharyngeal cancer, the orodigestive cancers, and you can see that it's a multiplicative risk, of the odds go up by almost triple when you do both. And again, that is a major issue for us to think from a prevention perspective. The other situation that we brought up here is that depression and tobacco are correlated, and in many ways, when in the short term, when the nicotine levels are dropping, because it only lasts 90 minutes and for the half-life, and so when the nicotine levels start falling, people go symptoms of withdrawal, and part of symptoms of withdrawal are low mood, what we call negative affect, irritability, anxiety, and feeling restless, and difficulty concentration, all these things that overlap with what the feelings of depression are. But things that don't go with this are things like apathy, worthlessness, loss of interest, I seem to have lost it, loss of interest, and loss of energy, suicidal ideation, possibly psychosis and guilt. So these are some of the symptoms, but the overlap is obviously the low mood, irritability, difficulty concentration. And so sometimes it can become difficult to figure out what is actually because of nicotine withdrawal versus what is due to actually an underlying depression or dysthymia. And some people may have both. The other thing is obviously he has COPD, and we can see that obviously he's got the effects of a tobacco-related illness. And you can see on this slide where, obviously the risk of lung cancer is really high in active smokers. The odds, are up there in terms of at 10 or 11. But COPD is about 4, and about 80 or 90% of COPD nowadays is caused by smoking mostly. And so we also see the effects on other respiratory illnesses like asthma, and if you work in remote areas and you have a client or with certain populations where there's a high prevalence of TB, smoking makes it worse, and they go from being carriers of TB into becoming active patients with TB. So lung cancer, COPD, adult asthma, sleep apnea, and tuberculosis. One of the things going back to the depression piece very quickly, we know that when people quit smoking, it is the equivalent, in a large meta-analysis, the equivalent of adding an antidepressant in terms of the effect size on their mood. What this means is, rather than adding a new medication, quitting smoking improves mood in the same order of magnitude as it would be for adding an antidepressant to that regimen. So getting people beyond that withdrawal phase, actually their mood will actually improve as if you added an antidepressant. So that's very quickly some of the biological features in the case. Of course, one has to pay attention to some of the other determinants of his smoking, and I think that's what things we will have you discuss now. Yeah.
Okay, great. So we're going to open up the floor to all of those of you who have joined us. So feel free to share your thoughts either through the chat box or by unmuting your telephone line. You can push *1. And on the screen right now, we've just highlighted a few things to consider. So first, how would you approach this client given, 1, his level of tobacco dependence, 2, he does not recognize the impact of tobacco dependence, C is ambivalence towards pharmacotherapy. Second question, are there behavioral approaches you would recommend? What are some other factors impacting this client's ambivalence? What other information would be helpful to assess? And what are some of the strengths that you could help elicit from the client to enhance motivation? So we're going to open up the floor now, either the chat box or through the telephone. I'll make this chat box a little bit bigger.
Hi, can I speak?
Yeah, for sure.
Okay, my name's Betty Wu Lawrence. I'm a public health nurse from Toronto. The scenario you presented, I have a similar client who is younger, and he's actually 34, and unfortunately has all the, except COPD, he's also a binge drinker and also a smoker. And now my question to Dr. Selby is, these people, this young man, he most probably in denial will not accept the fact that he could be depressed, and he's just been recently laid off. My question is, how would St. John's wort, the over-the-counter medication, be helpful at all?
Yeah, so I think what we would do is in these questions, I mean, certainly our panel will have an opportunity after. So I'm going to ask you to hold that thought. We will definitely answer that question, but if we could consider the questions on the screen and have you actually type in your result, your responses to it. If you're in a group at your setting, feel free to discuss it for a few minutes and keep typing in, because I think what we are looking at in the chat box is that everybody has similar clients and similar issues, and I think this is the whole purpose, is to think about how do we approach these issues where there's multiple morbidities, whether it's psychiatric, medical, and social, and which is impacting motivation, and we are kind of feeling stuck about what else to do next. And then we can think about how to organize our thinking, whether it's medication, whether it's behavioral interventions or some other interventions that we need to put in place. So I mean, I hope people on the online are beginning to type, and so let's see. These are some of the questions.
I'm on the phone. I won't be able to type in. Yeah.
Okay. So you can answer some of the questions by phone as well. That's allowed. But I would, if you are not speaking, I suggest pressing mute, because otherwise we're hearing your background. The background.
Oh, how do I press mute?
*1.
*1.
Thank you.
You're welcome. So the question is, what are the reasons for him wanting to quit?
Should I respond or?
Yeah, go ahead.
Oh, the reason he want to quit, he's aware of the consequences. He just cannot quit, and he's not motivated. No.
Okay.
Instead of posing questions for this activity, maybe what would be better would be to start brainstorming ideas and just pointing out his strengths, for example, or pointing out how you could elicit more motivation and such.
He's aware of the fact that I'm a nurse, and I think I have some rapport, and that is one of the things I do notice since I talked to him, started about a month ago. I noticed he's smoking, the quantity of smoking has been decreased. But then I have also observed he's more depressed, and he's less taking time to cleaning himself. So that's why I'm asking that how to convince him to treat his depression.
Right, and I think that's a similar situation for the case that for today. It's the similar issue around when there's a fear around taking appropriate treatment for the depression or what it means to them. So, I think we've got a few great recommendations and comments, and I think we're seeing that really first steps is to understand better from the patient what are the benefits of smoking, and then what are the costs of smoking for him, if any, and then in terms of the triggers, what he is doing that. So one way to look at it, all of them, is to map the agenda and seek a better understanding of his understanding of the connection between COPD, smoking, alcohol, not moving around, all those issues, how they all tied in with each other, and how that might be contributing to his loneliness and isolation as well.
Yes.
So the first step would be to understand that first, because one of the things that I'm observing is that the team appears to be working harder than him. Right. So let me hand it over to Alex and Melonie to comment as well.
So I see that someone has put here, Sandy has put, I would begin by asking the client what he felt he needed help with and which behaviors he has that he wanted help to change. His support systems would be helpful as well to know. So if we go back to that whole idea of the agenda mapping and talking about the relationship, we're going to be able to elicit from the client what his thoughts are about depression or dysthymia. What is that? What does that mean to him? What is his hesitation about possibly investigating that further? Then that whole idea of affirming the things that he's done in the past too, because I remember at the beginning when the case was being discussed that he is already using some strategies that he had used to help him quit his alcohol use. And so for me, when I think about this case, I really think a lot about, what are the client's hesitations about, how his mood and anxiety are affecting him. What do those labels mean to that person? How do those feelings or what he's experiencing affect his smoking? The other thing as well is pharmacotherapy. What is the hesitation there? What is his knowledge about nicotine addiction? What does that mean? So using that elicit, provide, elicit sequence where you're asking him, oh, so, you know, I know you've shared with me before that you're a bit apprehensive or worried about using this specific medication. Can you tell me more about that? And then reflecting back what he has said and seeing if you can develop some discrepancy. So between what he would like to do and what he's doing, the values of I think he wants better health. The other thing I'm wondering about too, and then I'll pass it to Melonie because I know she has some great ideas too. The other thing too is during those sessions when he's coming in, what's happening in those sessions? What is he talking about? Is there, you know, what's being reflected in that session? And then I think about that idea, like, you know, you've been coming here for this period of time, and I'm wondering how can I help you get to where you want to be, and then affirming what the person has done too. And then I'll pass it to Mel, and if I have more ideas, I'll speak up again.
A lot of really good suggestions have already come up sort of online. A lot of the things that I was thinking when I initially saw this case, when I first read it. The things that struck me, I guess that hasn't been said, was this idea of anxiety preceding relapse, but the idea that the anxiety actually comes when he's successful. So he's starting to make some gains, and then I imagine there's some sort of like, ooh, this actually could work. And I'm wondering if there's, which we see it's not uncommon, for clients to worry if they're successful, are they then going to lose the support of the health team? Sometimes that's sort of under the surface, but can sabotage people's success. Also perhaps wondering what this smoke-free life is going to look like. It sounds like he's quite socially isolated. He calls himself, you know, a loner, but I'm also hearing the desire to connect with other people, but maybe those opportunities don't exist. I'm wondering if he is attending AA. I got the sense that he was, but because it says like Alcoholics Anonymous for peer support, but it doesn't say that he's actually engaged. So something like that might be really helpful. The challenge, of course, is that at many meetings, there's sort of the gauntlet of smokers as people enter and exit. So perhaps finding a smoke-free buddy within one of those meetings, that might be a starting point, because the support there, some of the strategies you mentioned for alcohol have been very successful in terms of transferring that onto his tobacco cessation. I agree with what everyone said in terms of the pharmacotherapy. It sounds like that's an important piece. Typically here what we would start with is some psychoeducation around the symptoms of nicotine withdrawal and how these mimic both the symptoms of anxiety and depression. We actually have a really nice handout for that I'm happy to pass on. And sometimes that reframing is very, very helpful. I actually think reframing with this client as a therapeutic strategy would be very helpful. Many of the people who contributed online have talked about emphasizing his strengths, a stepped approach, so setting smaller goals, focusing on gains. I believe that's tremendously important. The other thing that I might add, and that might help with the buy-in about medication, is it sounds like he's already self-medicating for mood with tobacco. And maybe to frame it in that way, and again, it would depend on the relationship with the client. It sounds like you have a very good therapeutic where sort of that might be gently approached. And so, you know, if you're already using cigarettes, you know, how does your mood change when you're smoking versus not smoking? So starting with the tracking piece, if mood is going up when smoking, chances are he's using it to self-medicate. So if that's one of the needs that's being met by smoking, would it be okay for you to perhaps try a different medication that might be less harmful. I might kind of see if there's some wiggle room that way.
And if I could just add on to Melonie, when you were kind of talking about that relationship to the smoking and that idea, like what would that smoke-free lifestyle be for this person, I'm thinking about asking that question, like what would be the worst case scenario? What do you have fears about being someone who doesn't smoke? Or you don't know who you'd be without that cigarette? Asking the person what that would mean to them.
Yeah, I think that's one of the things so there are two things, Crystal. So first of all, thank you. We sort of skipped over the thanks for presenting the case, and it's a really interesting case. And what we will do is we will actually take a look at the entire chat later on, and we'll put it into the various domains. So you can go through the chat yourself, but we'll put it into the various domains for everybody to look at where the elements we're talking about. But I do two things for patients who keep coming back. So, but aren't actually, in our mind, benefiting from the interaction. And so what I actually do with such patients is actually I'll sit them down at a visit and say, I want to discuss how your treatment has been going from when you've come, and you've come for these many times. From where we sit, the treatment hasn't seemed to have benefited you. Help me understand what benefit you are getting from coming and seeing us for these things, and how could we make this better for you. So it does two things. So one, it is important for us to understand, because there may be benefits that we are not asking about that he's actually perceiving. The second thing is that there may be, and it also starts telling him that we are not just here to be just to come in for a chat. We're actually here to help clinically, and that we nudge an expectation of improvement or something, some participation of what needs to be different. And we don't ask him, what do you need to do different? We ask him, what do I need to do different? So, and second is this worst fear question. What is your worst fear if you took this medication, whether it's, natural products, whether it's prescribed products? What's your worst fear? And just listen to what they come up with. And secondly, we say, and as Alex said, what's the worst thing that will happen? I think, is it Basant who on the chat has talked about the issue about the security he feels. Many times, many of our patients who meet the criteria of addiction, which is continued use of the drug despite the harm. So he's got COPD, he's got all those issues. One of the things is to understand it in the terms of an attachment, because cigarettes possibly have been through his recovery, his divorces, or whatever, all his losses, and being alone. So that's the second area of understanding that you have to spend some time just understanding the attachment that he has in this situation. And lastly, what we always look at is look at the process of the supply. So who's supplying the cigarettes and where he's consuming them. Is his living space tobacco-free? How easy is it for who smokes around him? Is his travel tobacco-free? So those very basic, fundamental things, we go back to the basics all the time when these things are not seeming to be working. It's just to take that step back and just systematically go through those basic questions with him again, reviewing the lack of progress. Not in a blaming way, but to say, look, you're coming, you're expending the effort. Then we want to make this useful.
And that's the things you can affirm is you come and see us, you talk to us, you're trying to figure this out, and then kind of posing those questions of, well, how can we make this work a bit better for you, because this is something you want to work on, otherwise you wouldn't be here.
Yeah.
I'll often bring it back to the drivers of motivation, which is confidence and importance. So it's at least somewhat important to him because he keeps coming back, although we're not sure if it's for actually social gain that he gets from attending the program. But I'd like to go back to that. Several people have mentioned, why do you want to quit? So eliciting what those values are. and hooking the quit into what's important in his life. So is it health? Is it being free of this addiction? Is it having more money? Making it really personal versus these sort of broad abstract concepts of health that, while they're important in the moment when the person is triggered, don't necessarily have as much impact. So I'd want to go back to the pros and cons. Someone had mentioned that. The decisional balance is, in my opinion, one of the foundational tools, because we'll get at why he wants to quit, but also what's driving the smoking. Because it said in the case there's many triggers, but I wasn't sure exactly what those are. So I'd want to really flush out, in those moments when he does smoke, and that could be done through the tracking. And I think the tracking would also be, in my opinion, has been a very, very helpful tool. And it can be adjusted depending on what you're interested about. So if it's more withdrawal, you can track withdrawal symptoms. If it's more of these psychological components, perhaps the personal relationship with tobacco, mood, etc. Really trying to get a sense. And then starting with one trigger at a time. So if you're using the cigarette tracking forms where you're rating the importance of this, like how much do they need to smoke, starting with the easier ones first so that the person builds a sense of confidence. We know that confidence will improve with medication, with social support, with success. So how are you measuring success? Again, focusing on those gains that he's been making. In terms of building a non-smoking life, the other thing I found very helpful is people tend to think of smoking life and then non-smoking life. And there's sort of this giant pit or chasm in between them. And so how do I make the jump from here to over there? And that can be very, very scary for people. So what I encourage them to do is, while they're still smoking, test things out. Go to the Y, go for a walk. Start building in those activities that they think that they might want to try when they're not smoking. What happens then is, even though they may still be smoking, they're starting to build that non-smoking life concurrently. They're also getting periods of time then, if it is something like a gym or going to the library or something where they're in a non-smoking environment, they're actually building the times of not smoking. So that's been a really helpful strategy, and reinforcing that they can build whatever kind of non-smoking life that they want. So they don't have to be a militant non-smoker. They don't have to, there can be an element of fun in that as well. Melba had mentioned the idea of sort of groups, and that people having difficult, I think it was Melba, I apologize if it was someone else.
Can you make it bigger?
Discharging, having difficulty kind of discharging clients, yeah, it was Melba, at times, because I guess they've achieved their goal, and then they feel like they can't continue to access that support. Similar to this case, may also sabotage people's success if they feel like they're going to lose that support. What we offer here is an ongoing peer support group where people are welcome to come regardless of their stage of reduction or abstinence. So we have people very early stages who are highly ambivalent. We have people who are gearing up to quit. We have people who have just quit, and we have people who have quit for many, many years. And that's very helpful because people know they're not going to lose the support. But also, people who are further along in the process get to act as a mentor, and that's tremendously beneficial, not only to people starting out, but also to people that have quit for many years to take on that role. As they're talking in group, it solidifies their reasons for wanting to do this, and actually can be a buffer to relapse. So I know, Crystal, you mentioned there wasn't maybe capacity or resources, but I would say that even if you and your colleagues are assessing or treating even 3 to 4 clients in your clinic, that it may be helpful to consider this option. You'll get more bang for your buck, and it will also, clients just do better in group overall.
So could I just answer some of those questions? I think that one of the things that we realized very quickly when we were doing these groups was this. It's based on social learning theory, which means people who are ahead, who are doing better, often want to give back. And this has translated into even online groups. So here's what the other value of what happens in the group. I think we can share with you, but it can be as structured or unstructured as you want. There's often a check-in. There's a, obviously there's a way of people talking about what is their successes, what are their challenges. And if it's well facilitated, you don't have to be the expert at the front of the room. What starts happening is you get peer-to-peer interactions, much like what we are doing today in our group online, right? We are here as facilitators and providing some expertise, but you guys are coming up with all the main points and touching upon it. We're just simply nudging some of the conversation along. And you can see, hopefully, Crystal will get a lot more benefit from your collective contributions than what we are doing individually. There are 77 people, I think, online, 70 plus. So you can think about the power of that issue. And yes, you do need somebody, depending on the setting, you do need a health professional in the room, but you can look at a co-facilitator, like somebody who, depending on how your setting center is set up. Here's the other thing. We are in a state where expertise is being challenged. It's called, and there's this whole concept called a public use of science and the understanding. And most people, if they are strong believers against medications or, a whole bunch of things are happening. Everybody's the expert, and they don't want to trust us. You can, no matter how many arguments and evidence-based things you make, it's not going to change. But what does is emerging makes a change is if the peers talk to each other, and they talk to each other about, you know what, yeah, I took that medication and it was fine, or that's what really helped me. People can see themselves in that situation compared to not. So the group format creates these kinds of places where people, now the group, you can call it a workshop, you can call it you don't have, because everybody has different ideas of what, you could do it around a cafe style, you could do it whatever style you want to do it to bring people in. But it's, whatever will, the Quit Cafe, exactly, Michelle is talking about the CHC, the Chickamauga Quit Cafe. You could do a Quit Cafe, and so thanks for providing them that number, because that may be what is required. So within the context of where the patient finds themselves, you're doing cessation, as opposed to it's cessation, and they have a broader need of being connected, of being engaged, and of feeling empowered to make the change. So any final thoughts? I will just go.
So if I could just tack on to Melonie, when you talked about the non-smoking lifestyle, making these small goals to try to get out there and do things to change things up, and that's also a great intervention if you think of people whose mood may be low, that activation piece too, and it's really eliciting from the client what would work in their lives, what would they be interested in doing, and what are they able to do as well. So I just wanted to highlight that you're kind of getting two birds with one stone there.
Absolutely.
Anything else?
No, unless there's specific questions.
Okay.
I think a lot
So what I'm going to do is then I'm just going to summarize. So we'll summarize what we've heard and seen, and we'll put these also, we'll save this information. But overall, it became what's the motivation, and how do you, what's bringing him back, and obviously he's ready for some things. He's demonstrated that he can change, for example, giving up alcohol, and he's struggling with tobacco. But obviously these are some of the strengths, and then you do the decision balance of the pros and cons, and you find out what's going on. What are his fears about medications? Pay attention to the social isolation, possibly having some sort of groups. What are some small steps that he's willing and can take rather than big ones? So trial quits or trial smoke-free, hanging out in smoke-free places for a while, and demonstrating to him that he doesn't lose his shirt if he sits in a clinic for 2 hours without smoking. So start building those things for him. Affirm whatever successes that he has had. And then I think, as people have talked about the specific triggers, specific issues, one of the dangers of this is to get the writing reflex triggered, and you're going to come up with, okay, here's your quit kit, here's what you should do, and what you'll get more of is disengagement and more sort of ambivalence and yes but or sabotaging. So I think really not looking at that. And the other question is this some sort of mood management that he thinks is the way to go by using cigarettes? Because obviously in the short term he's going to feel a little bit of a withdrawal termination effect where the nicotine kicks in and he feels the withdrawal goes and he feels a bit better and he attributes that his mood is improving. And then again, of course, what's his worst fear? So I'm just going to go back. Typically our responses is to break it down into a biopsychosocial developmental aspect to things. So from a developmental perspective, what are his traumas in his life, and where has cigarettes helped him through that? And so I think paying attention to that is one key issue. The second thing, which is kind of developmental, but it's late life developmental, is actually this may not be motivation. It may be his actual abilities, which could be robbed by either a head injury or the development of dementia or the development of a significant depression that is interfering with his ability to actually do the things that he's not doing, and that might come across as lack of motivation. So teasing that apart is important, because depending on how severe his alcohol use disorder was, he may actually have deficits in his cognitive functioning. So I think paying attention to that, and so I'll put that into the developmental aspect over time. Environmentally, we talked about people, places, and things where smoking happens, and is he willing to make his living space smoke-free and his travel smoke-free, because those essentially are targets that help in preparation for reduction or cessation. So that's just a standard where people are not willing to stop, but they're just, by doing those things, they're reducing the cue exposure, so it's managing the cues and triggers. And secondly, if he's willing to create some distance between when the craving happens and when he lights a cigarette. Though, keeping the time from craving to cigarette, the craving to hand to mouth time should be at least half an hour to 20 minutes. And how he can actually delay that would be important. So environment, and again, social environment, are there buddies that smoke with him? Are there people who sabotage his, all those kinds of things? And conversely, are there motivators that who would care if he's quit smoking? I just simply, other than the healthcare professionals, who in his life who matters to him would care? So I think that's the environment that we would look. And finances. What is he not doing because of the money going towards this? And often our patients will tell us, within a week of quitting smoking, they're able to eat fruits and vegetables, they're buying shoes and buying clothes and things like that because they're just not spending money on cigarettes. Then we come to obviously the biological basis of things, and of course the depression. Now, if he's in the STOP program, he would have been screened with a PHQ-9, which you can still, and you would see what his baseline depression is. You could download the PHQ-9, which is a questionnaire that tells you the severity of depression, and that can tell you if he's actually meeting any kind of, you don't have to diagnose it, but it'll tell you that, look, you need for him to see a physician to make the diagnosis and start the treatment and turn back to that physician. So paying attention to that biology of his mental health biology. His physical biology, he says he has COPD, but he's not on any meds for it, so I'm not sure what that's about, whether he is. So because, again, if he's going to need home oxygen, if he's still smoking, that's not going to work. home oxygen and that. So I don't know where it is. Are there certain key issues? Has he been intubated? Has he been hospitalized? Is his COPD exacerbations occurring? All of those things. Yeah, and what's the limitations from his COPD and functionality? So bringing that in to the biology would be important. And of course, then psychologically, we've talked about it and summarized. First step is engage. Goals, values clarification is what I heard, and then goals clarification second, and then the methods to reach those goals as the final icing, the cherry on the top. Because if you put the cherry before the cake is ready, I think we'd be missing some of the key issues. So getting that, I would think it is how one should probably step back from this case and think about what there is for this individual, and then what is the capacity within your setting to actually do some of the things that we're talking about. So I'm going to stop it there just as that's the summary, and then we'll open it up for further questions or comments or what people think about it. And of course, Crystal gets the last word as to what she found useful or overwhelming or completely not useful from this exercise.
It's Crystal here. I'd just like to say thank you. I think it has really been helpful. Of course, like there are definitely some ideas that we've definitely explored and worked on, or that just have been kind of ruled out, and definitely using lots of motivational interviewing strategies, that sort of thing. But I've really come away with a lot of other things that I can follow up on and readdress or go back to. So I think the variety of ideas has been really helpful.
Yeah, and I was wondering whether you'd be, as things are progressing, either through the listserv or through this, to let us know what's worked, what's not worked, so that I think other people can benefit from your lessons learned as well, if you're okay with that.
Yeah, I can definitely, if there's some updates. The client's kind of working just with social work right now, taking a break from the tobacco program, just because he's in a bit of a downswing right now with the tobacco use. But definitely, our social worker dropped in here for a few minutes to listen to some of the strategies. So, and I know she had mentioned that there was some great ideas to be shared as well. And I think we will look into kind of that group piece as well. So any resources that can be shared around that would be much appreciated.
Okay, great. Other comments?
I'd like to thank everyone for their thoughts too. There was a lot of good insights there, and Crystal, I hope things get moving.
And then to answer that question about St. John's wort, I think if anybody's going to take St. John's wort, just because it's natural doesn't mean it's safe. I would check, because it can interact with lots of medications. I would check with the pharmacist as to what the person's taking that is potentially could interfere with St. John's wort, because St. John's wort is actually an MAO inhibitor, and it actually can cause quite significant side effects. And so making sure if they're going to use a natural product, there's quality, and that it's actually cleared by the pharmacist, because that might be problematic. So that's the question that came from Toronto. I'm not sure who was asking that question, but from Toronto. And so I also want to thank everybody. I want to thank the team for putting this together and giving it and for everybody for giving this a shot. We'd like to know if you like this format as opposed to more didactic, and or maybe we need a mix. And so let us know. This is very important because we try to make sure we are being responsive to what the needs of people on the call are, rather than what we think you should learn. So.
Yes, for sure. Please do be very candid on the evaluations. So the link to the evaluation and